Hey everybody, it's Dr. Gilchrist and welcome to the first week of our lectures. So for this week, we are going to start with an introduction to psychopharmacology. We're going to talk about the nervous system and we're going to talk about how neurons communicate with each other before starting to dive into the following weeks, talking about how different types of drugs work and how drugs are distributed throughout the body. We're going to start today by talking about an intro to pharmacology and in particular psychopharmacology. So we're going to start by talking about what psychopharmacology is. We're going to talk about what drugs are, and for the purposes of this class, we're going to spend most of our time talking about psychoactive drugs. If you don't know what psychoactive drugs are, don't worry, within the next 2 minutes, I will be sharing that information with you. But largely in this class, we're going to talk about what are called psychoactive drugs. And these drugs have different types of names, and I'm going to talk about the difference that some of these names have. We're going to talk more generally about pharmacology, and we're going to finish up by talking about research design and ethics. So let's go ahead and begin. What is psychopharmacology? So hopefully, if you know a lot about root words, and if you know a lot about word stems and things like that, you could probably make a pretty good guess as to what this is. So ology means the study of something. Pharma sounds like medication or drugs. Psycho implies something about the mind. So we can kind of get a pretty good idea just by looking at these different word parts that this is about the scientific study of drugs that specifically affect the mind, and that would be the case. So psychopharmacology is basically the scientific study of how drugs affect things like our mood, our perception, our thinking, better known as our cognition, or our behavior. Now, all of these things that I've mentioned, like mood, perception, cognition, behavior, all of those are products of our brain. So if we want to look at how drugs affect these things, these are going to have to be drugs that are actually capable of affecting our brain. So to be able to study these, we're going to specifically look at drugs that are called psychoactive drugs. These are drugs that specifically are able to reach the brain, and they ultimately end up affecting mood, perception, our cognition, or our behavior. So let's take an example by talking about ibuprofen versus fluoxetine, an antidepressant probably better known to you by the name Prozac. So if you have a headache, or if you pulled a muscle and you're in a little bit of pain, or you're like me and you get the occasional runner's knee, you might take some ibuprofen for that. Now, ibuprofen is a drug, but it is not technically a psychoactive drug. And some of you might be a little bit surprised by that because you might be like, well, Dr. Gilchrist, pain involves the nervous system. True. But ibuprofen does not work on the nervous system to reduce pain sensation. What it actually does is it reduces hormones in the body that cause inflammation, pain, and swelling. So it's working on something that is not involving the nervous system in that way. And so because it is reducing pain, but it's not working on the nervous system, it's not going to be able to affect things like your mood, your perception, your thinking, or your behavior. So ibuprofen relieves pain, but it doesn't really change mood. It doesn't cause hallucinations. It doesn't hurt our memory or attentional capabilities, and it doesn't really affect our behavior other than us being happy that we're not in pain anymore. Now compare that to something like fluoxetine, which is what is called a selective serotonin reuptake inhibitor. This is something that actually crosses into the central nervous system and crosses into the brain. It prevents reuptake of serotonin so that serotonin can stay in our system for longer, and as a result, it enhances the effects of serotonin. And because of this can potentially affect our mood. It can reduce depressed mood. It can potentially alter our perception, though probably not. You would probably get that with more of a psychedelic type of drug. It may potentially affect our cognition, and it may potentially affect our behavior. So one of these, fluoxetine, is a psychoactive drug. Ibuprofen, while a drug, is not a psychoactive drug. So why should we study psychopharmacology? And I know for some of you, you're taking this class because you want to get some extra credits, your major may require it. And so, yes, that is part of the reason that you are here taking this online class, but I really want to impress upon you how important it can be to study something like psychopharmacology. So I want to share some data with you. We tend to find that there are over 100 million plus prescriptions for antidepressants per year. We have about 80 million plus prescriptions per year for anxiolytics, so drugs that reduce anxiety, sedatives, and hypnotics. We have about 200 million plus prescriptions for pain relievers. So we're not talking about ibuprofen or Tylenol here. We're talking about opioids, things like Vicodin and OxyContin. And so those are just prescriptions. Odds are pretty good. You or somebody in your family or somebody in your friend group may potentially have one of these therapeutic prescriptions. Now, these are just for prescriptions. These you need a doctor for. Now, let's shift into recreational drugs. There are over 114 million consumers of alcohol on a regular basis. There are over 25 million people who use marijuana on a regular basis. And with marijuana becoming increasingly legalized here in the United States and elsewhere, these numbers are likely going to go up. There are over 15 million people that misuse prescription drugs on a regular basis, and this would be considered recreational use. There are 70 million plus who are using tobacco products, and that's not even counting caffeine, which many of us use, and newsflash, caffeine is a psychoactive drug. So in short, odds are pretty good that either you or somebody that you know are taking psychoactive drugs. And if you're like me and you drink coffee or the occasional Mountain Dew, you are also taking a psychoactive drug. So now let's talk a little bit more about what drugs are and what psychoactive drugs are. So I want us to get back to basics. What is a drug? So a drug is a substance that somebody takes or is given that alters physiological function. And one of the things that your book mentions, is that that's a really fuzzy definition. So the definition that's given in your book is a drug is an administered substance, so administered. So somebody administered this. So we can talk about the fuzziness of all of these different components. So with administered, that basically means that substances that are not made in your body don't count. Your body makes its own morphine, for example. Your body makes dopamine, but those aren't drugs. However, if somebody has Parkinson's disease and they take a precursor to dopamine, that is considered a drug. Or if you want to alter a patient's heart rate, you give them dopamine, you give them additional dopamine that they aren't making themselves, that suddenly technically has become a drug. Now, additionally, things like neurotransmitters. So for example, as another example, your body makes epinephrine on a regular basis. But if somebody has an allergic reaction to something like shellfish or a bee sting, they may have to give themselves an injection of epinephrine in the form of an EpiPen. When your body makes epinephrine, it's not a drug. But when you're taking it via an EpiPen, it suddenly is. Additionally, let's talk about things like vitamins and herbal supplements and food. All of these things, vitamins are not considered drugs. They're vitamins. And they can potentially, and they are administered, and they can potentially alter physiological functioning, but vitamins aren't drugs. The same is true with herbal supplements. Herbal supplements technically do not count. Additionally, there's food. So food can actually do things like alter our mood. It can alter our behavior. It alters our physiological functioning. So why is food not a drug? So this is, it's kind of interesting how all of this works. And your book goes into a little bit more detail as to the fuzziness of these definitions. Now, we're going to characterize psychoactive drugs ultimately based on their use. All psychoactive drugs are going to have an effect on the nervous system. That means they have potential to alter things like our mood, alter things like our cognition, potentially alter things like our perception, and also potentially alter our behavior. Now, when we take a drug, we could be using a drug instrumentally, or we could be taking a drug recreationally. So instrumental drug use is basically when we are using a drug for a specific purpose. We are taking this drug for a reason. So for example, somebody might be taking something like Prozac or Paxil to basically reduce depressive symptoms. So they're using it for a very specific purpose. Ideally, they are using it for what it was designed for. Some people may take coffee for the energy that it provides. That would be instrumental drug use. You're drinking coffee to help perk you up in the morning and give you more energy. And oftentimes we're going to find that these are going to be for therapeutic purposes. Now, people don't take coffee for therapeutic reasons, but people may take drugs like antipsychotics for treating schizophrenia, antidepressants for dealing with depression. They're often going to be taking these drugs for therapeutic purposes. Drugs that we would need to either treat something that is a physical disorder or a mental disorder of some kind. In addition to instrumental drug use, we can have what is called recreational drug use. And this is basically using a drug to experience its effects. So for example, taking alcohol to basically loosen up and experience the intoxicating effects. Now, on the other hand, I have occasionally heard of people who will use alcohol to reduce hand tremors, which can be caused by a lack of GABA. Now, if you're taking alcohol to reduce tremors, that might be considered instrumental drug use. I don't necessarily think it's the safest way to reduce your tremors, but I guess you do you. But most of the time, people drink alcohol to experience its inhibition, loosening effects, and to have a little bit of fun. Additionally, drug misuse will pop up under here. So for example, ADHD is often treated with different types of stimulants, such as things like Adderall or Strattera. But other people have discovered that by taking these stimulants, and these are people that do not have ADHD, that they can really, really focus, that they get this kind of focus of attention, and they want to experience those effects. This is somebody who was not prescribed this drug. Thus, as a result, it is what is called drug misuse. So these are drugs that are intended for an instrumental purpose, but they're used recreationally. So using ADHD medication to basically get attentional focus or to feel its effects, or taking things like cough syrup with codeine to basically get high when the whole purpose is that codeine is supposed to open up your respiratory passages. And that's why you would be prescribed cough syrup with codeine, but some people will use those kind of cough medications to get high. So that would be a case of misuse. Now, there's a Weezer song that I usually like to play on the very first day of class. If you have an opportunity, I would highly encourage you to listen to it. It is not a very good song, but the whole point of the song is "We Are All on Drugs," which is the title of the song. So one of the things that is kind of interesting, part of the reason that I play this, is that when we talk about drugs, we tend to talk about good drugs and we talk about bad drugs. So we say things like, oh, you know, the medication that you take for ADHD is really good because it helps people manage those symptoms, but taking things like meth are bad. Now, let's be very clear with the effects that meth has on the body and on the brain. It is not something I would recommend. However, ADHD medication has very similar mechanisms to recreational stimulants like methamphetamine. But the difference is that we view one drug as good because it was prescribed by a doctor, and the other one is bad because it was not prescribed by a doctor. So especially when I was growing up, I would hear, especially in the 1980s, and y'all, we're going to talk a lot about drug policy in the 1980s, the 70s and the 80s, the so-called war on drugs. But when I was growing up during that time, good drugs were those that were prescribed by a doctor. Bad drugs were those that you got off the street. But one of the things that we find is that bad drugs can have useful effects. So oftentimes, for example, drugs like cannabis, marijuana, those have often been treated as very bad drugs. When I was growing up, I was told it was a gateway drug for all other types of recreational drugs. But we know that cannabis can have beneficial effects, particularly for those undergoing chemotherapy or cancer treatment. And we know that good drugs, particularly those that are prescribed by doctors, can actually be really harmful. We are in the midst of a painkiller crisis because opioids, which were prescribed by doctors, were being overprescribed, and people ended up getting hooked on those drugs as a result. Now, in this class, when we're talking about different types of drugs, you're going to hear a lot of different drug names. And I want to make a distinction between what we would call a trade name and what we would call a generic name. So when I go to the store and I look for a drug trade name, I might try to go look for Tylenol. That's the brand name. That is technically what is referred to as the trade name. Now, if I go to the store and I get some generic Tylenol, it is not going to be called Tylenol. It is probably going to be sold under the name acetaminophen, or depending on what country you live in, it may be referred to as paracetamol. So when we talk about Tylenol versus acetaminophen, or ibuprofen versus Advil, or Prozac versus fluoxetine, we are making a distinction between what we call a trade name and what is referred to as its generic name. So the trade name is the trademarked name that a company has for a drug. The generic name actually tells you a little bit more about the classification of that drug. So the classification basically will distinguish this drug from others. And we're also going to talk a little bit about chemical names and what are called street names. So here are a couple of different examples. Let me move my head very quickly. Here are some common trade names and some generic names. So I want you to notice a couple of things. So here are some trade names. You have probably heard of many of these. So we have Prozac, which is a selective serotonin reuptake inhibitor. It's often used as an antidepressant, and it's under the generic name fluoxetine. Paxil is also an SSRI, and it has a different generic name, paroxetine. Now here's what I want you to notice. Despite the fact that these have different trade names and different generic names, the generic names are similar to each other, indicating that these drugs belong to the same class. Oxetine tells you that this is probably some type of SSRI and thus an antidepressant. Now let's go into a couple of examples of anxiolytics, drugs that are designed to reduce anxiety. So we have Xanax under the name alprazolam as its generic, and Ativan, which is lorazepam. Here we have the am endings. And so this may potentially indicate that these serve similar purposes. Now, here's where it gets a little bit more complicated. Here we have Celexa, which is an SSRI, but it is under citalopram, and then Lexapro, which is used both as an SSRI and an anxiolytic. This is escitalopram. Odds are pretty good These have very similar structures given the similarity of their generic names. And then to notice that we have a completely different class of drugs, we have Abilify, which is a partial antipsychotic. This would be used for things like schizophrenia, and it's aripiprazole. And so we can kind of see that with the generic names, we're seeing that we're classifying these drugs in different types of ways. And this is probably telling us something very meaningful about these drugs' chemical structures, and that some have similarities and some have differences. So looking at those generic names can tell you a little bit more about what drugs belong together in similar groups and which ones do not. Now, to make this even more complicated, we can talk about chemical names. Now, most of the time, you are not going to see these chemical names. Chemical names are basically telling you about the chemical structure. So, for example, I have listed 3 for you here. So we have buspirone, which is also an anxiolytic, like Xanax is, but it works in a different way. So Xanax would be considered a benzodiazepine. Buspirone is not a benzodiazepine. It's kind of off on its own, and unlike benzodiazepines, it's not habit forming. So it's kind of clear we have a very different chemical structure here. And this is often going to be prescribed for things like generalized anxiety disorder. Xanax often is going to be for more severe anxiety or for debilitating panic attacks. So here you can kind of see its chemical structure. And I'm not going to read all of this, it's quite a bit. Below that, you can see the chemical structure for Prozac. And then below here, you can see the chemical structure and the chemical name for Xanax. So if you are interested in learning more about the chemical structure of these drugs, this is where having a background in chemistry and organic chemistry can help. But generally, according to your textbook, the chemical name basically tells anybody with a sufficient chemistry background what this drug's chemical structure looks like. So this is something that if you have the chemistry background, you'll probably know more about this than I will. I only made it through general chemistry, and we definitely did not get into the chemical structure of things like this. But if you have sufficient chemical knowledge, you may be able to appreciate this. But I mentioned that in addition to trade names, generic names, chemical names, drugs may also have street names. Let's go back, please. So we have a drug, and then we have its street name. So recreational, this is often going to come into play with recreational drugs. And street names are often going to be used for those who use or sell or manufacture these recreational drugs. And generally, the street names may refer to what the effects of the drug are, what the composition of the drug looks like, or what the effects of the drug are. So for example, for drugs like benzodiazepines, like Xanax, Valium, or Ativan, that might be things like benzos, candy. So benzos is just a shorter name for benzodiazepine. Downers kind of tell you what the effect of the drug is. They're sedatives. They're designed to basically calm you down. Sleeping pills, tranquilizers, so these tend to have pretty sedative or hypnotic effects. Amphetamines are stimulants, so those are going to get us up, which is why they're sometimes referred to as uppers, speed, pep pills, or eye openers. Cocaine is referred to as coke, blow, rock, due to what certain forms of cocaine look like. Snow, again, kind of referring to its powdered form, and then crack. Dextromethorphan, which is often a low-grade opioid that is present in cold or cough medications. It's sometimes referred to as DXM, Robo, or Dex. Marijuana, weed, or pot. MDMA, when I was growing up, it was referred to as ecstasy. You might have referred to it as Molly. Phencyclidine, probably better known as PCP, or angel dust. So these are some pretty common names for different types of recreational street drugs that are out there. So when we talk about drugs basically are based on a dosage. So when we take a drug, the effect that we get ultimately will depend on the dose. So a dose is basically a ratio of the amount of drug that you will give per that organism's body weight. So for example, something like 1 gram per kilogram in laboratory rats. So we need to know what the weight of the lab rat is for us to give a certain type of a drug. So if a rat weighs 1 kilogram, it would get 1 gram of a drug. If a rat weighs 0.3 kilograms, it's going to get 0.3 grams. Now, some of you may be kind of curious. Well, Dr. Gilchrist, what do you mean that this is based on body weight? The dosage for Advil is the same for me and for my friend, and we are different weights. I understand that people weigh differently. But one of the things that you are going to find is that these drugs like Advil and Tylenol and the kind of drugs that you would buy over the counter or even some drugs that are prescribed, they're going to be assuming an average body weight. And generally that average body weight is going to be about 150 pounds. So what you're going to see is that now with certain types of doses where the dosage really matters more, they are going to look at your weight to help determine the dose. So if it says take 1 to 2 times a day, if you're on the lower end of that range, you're probably going to take it once a day. If you're on the higher end of that range, you're probably going to need 2. So sometimes we do this, but if we're talking about things like Advil or if we're talking about Tylenol, most of the medications that we give people assume an average body weight. And this is partially, it's not the only reason, but it's part of the reason why when you go to the doctor, one of the first things they're going to do is weigh you. And I know that especially if you grew up in certain times when body image body standards were a lot more rigid than they are right now, going to get weighed at the doctor can be really nerve-wracking, but part of the reason you are getting weighed is that if you need medication, they can figure out what kind of dose you need, because especially if we're talking about drugs where overdosing can be very easy and very dangerous, you need to get a very precise measurement. But one of the things that we are going to find is that assuming average weight has some unfortunate implications as a result. And one of the things that we know is that in general, people now weigh more than they used to. And we're not really going to talk a lot about why. That's an issue to kind of bring up in my health psychology class. But this has some really important implications. So, for example, a lot of women take hormonal contraceptives to basically prevent things like pregnancy. But hormonal contraceptives were originally tested on average weight women. As a result, one of the things that we didn't know is what this would look like on women at higher weights. And one of the things that we do actually find is that hormonal contraception is less effective at a higher weight. This is especially true for things like emergency contraception. So for those who may not know, emergency contraception, it's sold under the trade name as Plan B, but there are a lot of generics out there. Plan B or emergency contraceptives are just higher doses of things like the birth control pill to basically if you miss contraception, it's basically an opportunity to get some more of those hormones to prevent pregnancy. So one of the things that we know, Plan B, so there's a lot of data out there that shows that Plan B and emergency contraception does not work as well for women with a higher BMI. So Plan B and things like that, it's over the counter, but we basically in 2011, what they ended up finding is that women who have a BMI of over 25 are more likely to become pregnant after taking emergency contraception. So many studies have found that because these effects were only tested on average weight women, that we didn't really know what the effects were for women of a higher weight, and it does leave a lot of those women in a bind if they need emergency contraception. Now, to add further to the point, one of the things that we know is that for a lot of clinical trials for different types of medication, women tend to be underrepresented. So I pulled this up from some data from the Harvard Medical School. More data needed. Study shows that females underrepresented in key disease clinical trials. So researchers from Brigham and Women's Hospital examined participation of females in adult cardiovascular, psychiatric, and cancer-related clinical trials and found that among trials for therapeutics in these areas, the percentage of females did not reflect the proportion of women affected by the disease. This was especially striking for clinical trials investigating drugs and devices for psychiatric disorders, where females make up 60% of the patient population. They are taking more of the drug, but they are underrepresented. So you can kind of see these are cases where there needs to be more representation of women because there are a couple of things that differ between the sexes. There are differences in weights. Generally, people who are assigned female at birth are going to be smaller than people who are assigned male at birth in adulthood. Additionally, there are differences in metabolism. So this is going to be really important, particularly when we talk about alcohol. There are differences in metabolism due to differences in body composition. People who are assigned female at birth have more body fat. Additionally, this comes into play for looking at things like side effects, etc. So the assumption of average weight and this assumption that the average clinical trial participant is assigned male at birth has some implications for the drugs that we take. So this is an instance where more understanding and more data is clearly needed. Now, as a general rule, the higher the dose, the greater the drug effect. So the more ibuprofen I take, the greater pain relieving feeling I am generally going to get. So what you're looking at here is what is referred to as a dose response curve. So basically this is going to tell you the effect of a drug based on its dosage. So what you're kind of looking at on your y-axis are the percent of individuals that are getting effects from that drug. And then on your x-axis, so this is your y, this is your x, on your x-axis, you are getting the logarithmic drug concentration that's present in plasma. So what you can kind of see here, this is the dose response curve. It's going to grow and it's going to rise until it eventually asymptotes. At this point, everybody is experiencing that therapeutic effect. But what we're interested in also is what is referred to as the ED50. This is the dose that produces half of the maximal effect, or the dose that is required to produce a therapeutic effect in about 50% of the population. By the time that you get up to this asymptote, at that point you have what is called an ED100. There's a therapeutic effect for everyone, and this is a dose that will produce the maximum therapeutic effect. And one of the things that you might find kind of interesting is that looking at dose response curves can tell us a lot of really interesting things about drugs. So what you're looking at here are dose response curves for 4 different types of pain relievers. So we have hydromorphine, morphine, and codeine, all of which are opioids, and then we have aspirin. It's a pain reliever, but it works in a very different way. So it's not an opioid. So the x-axis is basically going to tell you how potent the drug is. So notice, for example, that you need very little hydromorphine to get a big effect. Notice here, maybe 2 milligrams or a little bit more to get a pretty decent effect. Now, for morphine, you're going to need a little bit more. You need a bigger dose. For codeine, you're going to need an even bigger dose. And for aspirin, you need an even larger dose. So this is going to tell you how quickly and how effective this drug is. How quickly the drug reaches asymptote tells you how quickly this drug binds to certain types of receptors. So we get some really fast binding with hydromorphine. You can see that it asymptotes very quickly. Morphine takes a little longer. Codeine takes even longer, and aspirin hasn't even asymptoted with 100 milligrams or more yet. So this is not very effective at receptors the way hydromorphine is. Additionally, if you look at the shape of the curve, it can tell you whether or not you're dealing with a similar class of drugs or not. It tells you what kind of receptors might be involved and what their mechanisms are. So notice that the shapes of the curves for hydromorphine, morphine, and codeine look really similar to each other, and they should. They're all types of opioids. Hydromorphine is more effective than morphine, which is more effective than codeine. Notice that aspirin has a different shape, and that shows us that it's not an opioid. Its pain relieving occurs through a different mechanism than binding to opioid receptors. Now, in addition to telling us a lot of different things about a drug, they can also tell us how dangerous a drug is. And another ratio that you need to know about is what is referred to as a therapeutic index. This is the ratio between a therapeutic dose of a drug and the lethal dose of a drug. Generally, so it's a toxic to a lethal dose, or it's a ratio of a therapeutic dose to a toxic dose. So the higher your therapeutic index is, the safer your drug is. So for example, something like aspirin or ibuprofen may have a very high therapeutic index. Can you die? Can you die from taking too much aspirin? Oh yeah, but you're gonna have to take hundreds of pills for that to have an effect. On the other hand, consider something like alcohol, or consider something like really strong opioids like Oxycontin or hydromorphine. They have a very low therapeutic index, which basically means that there's a very small margin of safety between a therapeutic dose and a lethal dose. And generally what we're going to find is that the lower the therapeutic index is, the more highly regulated and carefully prescribed that drug is going to be. Now we're going to get to a really weird exception to this with alcohol, which also has a very low therapeutic index, but we have a really weird relationship with. And we'll kind of talk about that more when we talk about drug policy. So generally, the therapeutic index is represented this way. It's basically the toxic dose over the ED50. So now let's finish up by talking about pharmacology. We're going to talk about this more next week when we talk about pharmacodynamics and pharmacokinetics. But let's give you a very brief understanding of what each of these things mean. So what do these terms mean? So pharmacodynamics are basically the physiological actions of drugs. So basically how they act on the nervous system, what receptors they bind to, and things like that. Pharmacokinetics, so when we think about kinetics, we're kind of thinking about motion. So pharmacokinetics are about how drugs actually pass through the body. So for example, we know that nicotine reaches the brain faster with things like smoking than through snuffing or chewing or things like that, or a patch. And so what we're going to talk about when we get into pharmacokinetics is that certain routes of administration lead to faster drug action and experiencing drug effects more quickly than other methods. So let's talk about the difference between drug action and drug effect. So drugs basically are going to enact molecular changes when they bind to receptors. This is what we refer to as drug action. Now, on the other hand, we're going to get things like changes in our physiological and our psychological states as a result. And it's the changes in our physiological states and our psychological states that are the drug effects. So for example, a drug action would be, I drink caffeine and it blocks adenosine receptors. That's a drug action. But the perkiness and the extra energy and the boost to my mood is going to be a drug effect. Additionally, your textbook talks about the difference between what are known as objective effects and subjective effects. Objective effects are things that can be observed by other people. Somebody can measure your heart rate and see that it's going up. And then we have subjective effects. These are occurring internally and they can't be observed by other people. Now, drugs can have different types of multiple effects beyond subjective and objective effects. There are therapeutic effects. These are the desired physical or behavioral changes like caffeine providing you with energy. It reminds me of a wonderful bumper sticker I saw when I was in graduate school that said, coffee, do more stupid things faster with more energy. And I have never related more to a bumper sticker in my life. Now, in addition to the therapeutic effects, sometimes we're going to get side effects. So for example, these are effects that we don't want, but they come into play anytime that we take a drug. So we may get therapeutic effects, but we may also experience side effects. So for example, caffeine leads to an increased heart rate, possibly insomnia. If you have essential tremor, it can increase that tremor. So we have a difference between the effects we want and the effects that we don't want, but come into play anytime that we take that drug. Additionally, we can have what are called specific versus non-specific effects. So specific effects are basically those effects that are based on interactions between a drug and its receptor sites. But non-specific effects are things that are based on your own individual characteristics like your mood or previous experiences with the drug. So for example, we know that previous experience can affect how you respond to different types of psychedelics. Or we also know that the emotional state that you are in can affect how you respond to psychedelics. You are a lot more likely to have something like a bad trip, which would be a non-specific effect if you are generally already prone to anxiety, being nervous, or agitated. This can also include placebo effects, which are also non-specific effects. So now we're going to talk a little bit about research, design, and ethics, and this is where we're going to finish things up. And just as a reminder, I am not going into as much detail as your textbook does, so make sure that you are reading up, especially on sections regarding clinical trials and animal research, because I'm going to be a little bit more cursory with those. So when we talk about research design with drugs, we don't just design a drug and then just hand it out to people. We need to actually test it to make sure that it works. And so when we talk about doing research with drugs, I'm going to kind of dive into some research method stuff for you. Drugs and drug effects are variables. We are introducing a drug and we want to see what happens as a result. So we have to talk about independent and dependent variables. Now, in research, variables are things that can change. They vary, hence they're called variables. And we can have what is called a dependent measure, what the researcher is measuring, and we can have an independent variable. These are treatments that are designed to affect the dependent variable. So for example, if you're interested in alcohol research, you might be interested in the effects of different doses of alcohol on things like working memory capacity. So my independent variable would be how much alcohol I'm getting. I am directly manipulating that to see how it affects working memory. And then what I am measuring is working memory capacity. So we do actually need to do research to see if drugs can work. And your book talks in a little bit more detail than I will. So again, make sure that you read this. There are two different types of studies that they're typically going to do. They are either going to do a correlational study or they're going to do an experimental one. So in a correlational study, the independent variable is not going to be manipulated in any way. It is going to be measured. So for example, we can find people who have a history of taking drugs like MDMA and basically see how long they've used, get a measurement for that, probably through self-report, and then take a look at their memory performance, which is our dependent variable here. And we're going to see if they correlate. We can also do an experimental study where we are directly manipulating the dosage of a drug to determine different types of effects. Randomized clinical trials, which are often used to see if drugs can be used to treat therapeutic effects, are a form of experimental studies. Now, we need to have a few safeguards when we do experimental studies. So we need to actually make sure that a drug works. And so one of the things that we know is that psychology and belief is a really powerful thing. And sometimes the belief that you are actually taking a drug, even if you are not, can lead to improvements. This can be a placebo effect. So when you're taking a drug, you have to deal with the fact that there's a psychological component, your belief in the drug, and there's that physiological, biological component. So we want to try to tease those apart. So when we're testing to see if a drug works, we're going to give a control group a placebo. It's going to be something like a sugar pill. So this sugar pill actually has no physiological, biological effects. So if we see a change with the placebo group, we'll know it's because of the belief in the drug itself. And we'll compare that to the group that gets the actual drug. And ideally, if this drug is effective, we should see changes in the group that gets the actual drug, but not the group that gets the placebo. Additionally, this allows us to compare the physiological versus the psychological effects of the drug. And we can do what is called a single blind procedure. So in this case, the participant doesn't know what they're getting, but you as a researcher, if you know who is getting what, you have the potential of treating people differently. So oftentimes randomized clinical trials will have what is called a double-blind procedure. This means that neither the experimenter nor the participant knows if they are getting the drug or the placebo. Somebody else does, but they're not going to be involved with any part of the experiment beyond assigning people to those conditions. So by the experimenter not knowing what they're getting, we have assurance that we're treating all of our participants the same way, and we can make very sure that a drug has the desired effects and that it's not due to differential treatment on the part of the experimenter or a placebo effect on the part of the participant. Now, testing experimental treatments can be risky. And because of that, researchers will often test on animals long before they test on humans. And part of the reason for that is that there are often a lack of good alternatives, and there are generally going to be high predictive value for effects in humans. Generally, if it works in a rat, it's going to work on a human. Now, that does, of course, lead to some problems. Rats are very different from humans. Additionally, there are certain things that are harmless to us, but are harmful to animals, and vice versa. You and I can eat chocolate, but it will probably kill a dog or a cat. You and I can eat raisins. It will kill a dog or a cat. A guinea pig can have strychnine, but it will kill you or I. So we do need to be careful when we extrapolate drug research from animals, particularly rodents, to humans. We see this a lot with drugs like, with substances like aspartame, artificial sugars. People are often referring to research studies that look at rats that have been given mega doses of aspartame. And people will point to the unsafeness of aspartame by specifically referring to those studies of rats developing cancer. In a human, that would be the equivalent of getting about 2 packs of aspartame, like 2 packs of soda a day. That's how much you would have to have. Most of us are definitely not drinking that much. So always be careful when you extrapolate from rats to humans. Now, because animals do not have the capability of speaking up for themselves, animal research is very highly regulated through use of IACUCs and the Office of Laboratory Animal Welfare, which you can read more about in your textbook, as well as the Animal Welfare Act. So next time we are going to talk about the nervous system and its different components, and I look forward to seeing you there. Bye.